marking technique, principles, and pearls, and it also show a few other devices for image-guided implantation.
Yeah. Hello. Yeah. First of all, thank you, Haripriya. I'm not supposed to be here. Actually, Harshul is a dear friend of mine, and he's down for election, so I'm just taking his role. And I found some presentation. I may not be able to do full justice, but nevertheless, you will get a good message that you will take home. Overall view, I'm going to talk about indications, pre-op assessments, intraoperative aids, and post-operative assessments. I won't talk of post-op, but I'll talk about pre-op assessment a little bit. But what is the percentage? 70% of our patients have 0.5 pre-op astigmatism. So toric has a big role in our practice, and surgical induced astigmatism, we all have to know our SIA, should be between this and this, depending on whatever technique you're using or whatever size keratome that you're using. So what are the real indications of using toric IOLs? Of course, it's with the rule astigmatism or against the rule astigmatism. We're going to select cases, and where are we going to get our keratometry from, and which astigmatism are we really going to follow? So pre-op assessment is very important to know your keratometry, to know your astigmatism, know your posterior corneal astigmatism, IOL calculation, selection, and limbal marking. This is very, very important. I'll tell you how. Now, automated astigmatism, so you have an auto K, you have topography, and you have different methods of topography, and you have different ways of getting astigmatism. I'll tell you which are the different methods. But posterior astigmatism did play some role, and the first role was, of course, said by Douglas Koch, that is with the rule astigmatism is on the posterior curvature of the cornea. So there is a tendency for overcorrection in patients with the rule astigmatism and undercorrection in patients with against the rule astigmatism. There is a nomogram, and the new formulas looks at this posterior astigmatism. How do we get to know the posterior astigmatism? Any of the sham fluke imaging systems like the Pentacam, Galili, or OpScan, which is also possible, and that will give you a posterior astigmatism. And the new IOL formulas incorporate this. Coming to IOL power selection, it depends on this, and of course you get this different formulas which are there on the net. You just have to go to the ACRS or each company, whichever company toric IOL you are using, they will give you an IOL calculator, so you don't have to really worry about it, but you must know that. The most important question here is, where will you get your keratometry from? You have an auto K, you have a sham fluke imaging system, either a Pentacam, a Galili, or whichever system you have. You have Virion, which also gives you a K. You have optical biometry, which gives you a K. Now the question here is which to follow. So this cost about 476 lakhs, this cost about 30 lakhs, this cost about 30 lakhs, and this cost about 20 lakhs. So I'm not trying to tell you put 1 crore and you'll get accurate keratometry. Okay, but the question here is what will you follow? Now with immense experience, not as much as what Haripriya has, but what I do is I get an image from Virion. Okay, so that's an image that I've got, and I will put it in the calculator of the company. So if you're using an Alcon toric, or if you're using a Johnson & Johnson toric, or you're using whichever company, they have a calculator sheet which you go on the net, which is free to everybody. I put that image, the actual length comes from the optical biometer. The keratometry will come from the Virion, and I'll look at the Pentacam and look at it whether it's almost close. And that reading, or from the optical biometer, the keratometry, and that reading I'll put into the calculator of the company that toric IOL that you're using. And then put the same readings in the Virion. So that's how I manipulate as far as the keratometry goes. You have the Barrick toric IOL calculator. Now when it comes to manual marking physically in the OPD, it's very, very important that these are 3 points. Okay, this point has to be at the limbus. If this point is little above, you will be above 180. So very, very important, if you have a marker which does only 180 marking, please do not do it. So there are various ways of marking the patient. One way, you can put the patient on the slit lamp in the OPD, make the light straight on the pupil so the pupil constricts, and then your light when you're marking should be through the center of that. Okay, I'm not doing that, I'm used to this for years. This is called a bubble marker. Okay, this is freely available. The bubble has to be in the center. So if your hand is tilting, and make sure the head is straight. If the patient's head is down or up, again you'll be wrong in your marking. So make sure that is sure. And I put a torch in the eye so that the pupil constricts, and then I mark. If this limbal marking has to be right, there are some high-end markers available here which are electronic. So if you tilt your hand, it becomes red. If your hand is straight, which looks after cyclotorsion, it becomes green. So these are also available in the market. Intraoperative, I'll show you there are different ways of doing it. Intraoperative digital marketing is also possible. Preoperative factors, as I told you, If there's a 1 degree change, it will rate to 3.3 degree, 10 degree shift, it will change more than this, and 30 degree shift of your toric IOL is null and void. So it acts just like a foldable IOL and it will have no effect. Now this patient is operated with RK, and RK you will not get a Virion image, so there is no digital marking that's going to work here. So I'm doing a manual marking. What is important take home message right now in manual marking is that I have already planned in my head, because I put the patient on a slit lamp and I've decided that I want to make an incision between the two RK cuts, which comes to 150. So I put the patient on the slit lamp, make the light at 150, that's the slit lamp light at 150, and I know that there is no RK mark there. So I've decided that my SIA, which is 0.3, is at 150. Now I have to place the toric IOL at 24 degrees. So just watch what is to be done. So I've done the marking. This is 180, this is 0. All the marks are matching, and now it's at 24 or 25 degrees, and I mark. Okay, so I got that mark position, and that is followed by making the other mark at 150. So I've decided that in an RK, this is an 8 cut RK. It will be different if you have different cuts RK. So I've got this, and this is 150, and I'm making a mark here. So this is manual marking. So you have this at 180, you have 90, and the incision is between two RK cuts. So of course I've decided that my keratome of 2.2, there's enough space for here. If I go this beyond, this and this cut can open. So that's one care that you have to take, and this is just followed by routine surgery. Now a tricky case with keratoconus, I did intacs, okay, and then I'm marking, and then I'm going to put a toric IOL. So this gives excellent results, believe you me. If you have intacs inside and if you do a cataract, the patients read N8 with a monofocal IOL, because the cone itself is well centered, it gives the depth of perception, and the patients can read N8 with a normal monofocal IOL. So this is marking, and once the marking is done, I put a little bit of dye so that that enhances the marking. You have to be a little careful when you're making your incision with the intacs, but that is what care we have to take. And then we go ahead and do your routine phacoemulsification, which is nothing different. The intact ring itself gives you a size of how to mark, and this is followed by IOL placement in the bag. And then making sure that the marks are aligned. So you can see that there are 4 dots here. This is the marking which I had made manually. This has to be rotated and placed. Always make sure that your IOL is little ahead before the marking. If your IOL rotates beyond the mark, you will have to go all round, okay? Because this is the curvature of your lens. To rotate a lens anti-clockwise is much more difficult than to rotate a lens clockwise, okay? Because this is the position of the haptic, and that's one important thing that you have to do. So initially, always leave the mark little ahead of the marking, and then rotate the lens into position and make sure. I think what Dr. Meenu said about making it in the straight line is very important. This will be the last case. So here I'm giving you a take-home message. You don't need to have expensive instruments. These are two things together. I've done a manual marking. So this is manual marking, okay? This is Virion, and I'm trying to say that manual marking is as accurate as digital guided marking. So whether you have a Callisto, you have a Virion, you have manual marking, it all works very, very well, and this works quite okay. So there's nothing to be disheartened if you don't have it. You can do your manual marking. And one more interesting information I want to give to the panelists, that first time in my life I saw this. I have Virion, and I put the lens under the Virion, and shockingly, the Virion gives what axis the lens has to be placed. So I don't understand how Virion actually diagnoses, because Virion technically is supposed to work only on the eye, because it takes an image of the limbus, it takes an image of the iris. Now can you see this is the lens, and I got Virion on it, and it displays the axis. So how it does it, why it does it, I have no idea, including Alcon has no idea. So we are all in the same boat. But here I'm placing Symphony Toric IOL at 84 degrees. It goes in the same axis. And Virion is very useful. You should have it, because when you want to place at 24 degrees, 26 degrees, 36 degrees, all this, it gives a fantastic thing. This is the last this thing. This is a corneal opacity. Just to tell you, to take home message, that this is manual marking. And here I'm putting an IOL with 12 diopters of astigmatism. This is a customized IOL. These are called smart torics. They give excellent results. You can see a 21 diopter IOL with 12 diopters of astigmatism. Believe you me, brilliant results. It's made by IOCare. I have no financial interest, although I'm open for a discussion. But there is nothing there, and these results are very, very good. I'm sure all the rest on the panel have used these smart IOLs. They give very, very good results. Thank you, and if I've been short for anything, I'm sorry about that.
Thank you so much. Last minute. Yeah. Thank you so much. That was a great talk. Thank you, Dr.